Hello, everyone, and thank you for joining us in our international webinar series, the first webinar entitled Catalyzing the Impact of Research Through International Evidence-Based Knowledge Exchange. My name is Baltica Cabiesas. I'm a social epidemiologist. Sorry about that, technical mistake, but we're back. So we are extremely happy to be here with you, representing 3 universities who are coming together to produce this international web series starting today. Today's webinar is called Chronic Pain, Evidence from Chile and the UK. Pontificia Universidad Católica de Chile, from now on PUC, Universidad del Desarrollo in Chile, UDD, and TSED University, TIS, have recently developed a strong partnership to strengthen international teaching and research innovation. With this aim, this international webinar series aims at catalyzing the impact of research through international evidence-based knowledge exchange between these 3 universities, 2 located in Latin America and 1 located in Europe, and in potential collaboration with other relevant institutions in England and Chile. These 3 universities, PUC, UDD, and TIS, have planned a list of webinars related to selected topics that are of mutual interest. A total of 5 webinars will be executed monthly, generally over first Monday of every month, via Zoom seminar provided by UDD, and with live streaming at UDD TV and YouTube channel. Thank you for those who are joining us today through UDD TV or at this link seminar of UDD Zoom. To start with this very first seminar related to chronic pain, evidence from Chile and the UK, we will start with short welcomes from authorities or academics from each of these 3 universities. To start with, I will welcome TSED University to give its welcome through the academic Fading. Dear Fane, please welcome. Thank you for being here today.
And thank you for having us, Baltica, and thank you everybody for coming. It's lovely to collaborate with you across the pond in South America, and it's great to share knowledge together. So we're really looking forward to hearing what our panelists have to tell us today. Thank you.
Thank you so much, Faye. Thank you for having TSED University and for pushing through your work and effort this wonderful partnership we are developing with PUC and UDD. In terms of Universidad del Desarrollo, I am really happy to give the welcome to this cycle of webinars. I work as the director of the Center of Global Intercultural Health at ISIN, the Institute for Science and Medicine Innovation at Universidad del Desarrollo, which is based at the Faculty of Medicine, Clínica, Alemana. Our center is devoted to develop research through global partnerships and through things that are related to global public health. And of course, chronic pain is one of them. The partnership with TSED University brings us joy, satisfaction, and great hope of what can be developed over time in this partnership from evidence-based exchange, research of common interest, and of course, social impact and public health impact. Thank you again for joining us. Now, from PUC, I will welcome Associate Professor Manuel Espinosa, who will also give a welcome from the part of PUC University. Manuel, please welcome.
Thank you very much, Baltica. I don't think I can initiate my video. Unfortunately, it's blocked.
Try again, please.
Okay, great. Well, thank you very much, Baltica and colleagues. It is a pleasure to be today contributing from our university, specifically from the Faculty of Medicine, where we are based. Here we are located in the Department of Public Health of the Faculty of Medicine and the Health Technology Assessment Unit of the Center for Clinical Research of the university. It is a pleasure to be connected today, and I wish you the best for this seminar and the forthcoming ones.
Thank you so much, Manuel, for your welcome as a representative of PUC. And now we will start with our presentations. We have 2 experts on the subject of chronic pain. To start with, I will invite Paula Zamorano from PUC to share with us her thoughts and experience in relation to chronic pain based in Chile, of course, at PUC. Paula is a physiotherapist and project manager at the Faculty of Medicine, Universidad Católica, in relation to chronic pain. Dear Paula, welcome. Thank you for coming today to share this webinar with us. You are most welcome to start your audio, your camera, and of course to start sharing your slides with us. Thank you.
Thank you, Baltica, for the invitation. Okay, so can we check that you can see the presentation?
Yes, we can see really well.
Yes.
Thank you, Paula.
Okay, thank you everyone for listening today to this interesting seminar about non-cancer chronic pain. In Chile, we've been working for the last years in this matter, and we've been advancing some innovations in the health system that I'm going to share with you today. So my name is Paula Zamorano. I'm a physiotherapist. I have a master's in health administration, and I work at the Faculty of Medicine of the Universidad Católica. And today I'm going to share with you the interdisciplinary intervention strategy for people with non-cancer chronic pain at primary health care centers that we've been piloting in Chile. A little bit of the background in Chile. The magnitude of the prevalence of chronic pain is around 32%. That is pretty similar to other countries in Latin America. The cost of health, of the overall health that is represented on the management of chronic pain is the 5%. And in our country, as in many other countries as well, we have a high impact on productivity and absenteeism as a consequence of prolonged medical leaves of these patients. On the health system, we have some important access barriers, where first the capacity is very limited on primary care, where the prioritization of the health services is mainly based on the HES, on the explicit guarantees of health. There is a national program that we have here in Chile. Then the drugs or the medications are restricted to certain diagnostics, certain range of age of people, and certain medications for a certain period. So there are strong barriers in access to those medications on the health system, on the public health system. And also the services offered at the primary care are mainly based on the medical consultants. There's a lack of services offered in other areas of physiotherapy, occupational therapy, nutrition and dietitian, etc. Despite that, we have done some advances in the area, in this matter. Further research has been provided mainly in cost and consequences, estimating how much is the cost and the consequences of chronic pain in our country, where Manuel and other people of our team have been constantly providing research. Also, public policies have been provided and proposed from the Universidad Católica for the management of chronic pain. And the government, 2 years ago, released a technical orientation for the approach of chronic pain at primary healthcare. Despite that this technical orientation has not funding associated, at least is a first step that the government is putting into their priority, the approach of chronic pain. Also, they've been working on a fibromyalgia and chronic pain law for the last years. This law is in an advanced stage, probably is going to be approved in the short term. So that is a very good news also for our country. And for the base of the approach at primary health care, we already have implemented the family and community model, but our country started in 2017, changing the single diagnostic approach to a multimorbidity approach, where myself and other colleagues participated in a very strong manner in that transition. So what we do in the Centro de Innovación en Salud Áncora UC, that is from the Faculty of Medicine, when we identify these relevant gaps for the health system, for the population, and for our patients, we review the international and national best evidence and practices for them to design an intervention strategy that can be inserted in the real context in our health system. This design, the most of the time, is collaborative between academics, clinical teams, decision makers, and then when we have a final design of these strategies, we pilot those strategies in the real context, evaluate, and then extract the main learnings to consolidate and propose a scale-up policy. So in chronic pain, we are piloting, we are in that stage, and it's what I'm going to show you next. The team that has been working, I've been working with Teresita Varela, that is a family physician, and she's the technical manager. Macarena Zulueta is also a family physician, and she's in charge of all the operations in the primary healthcare settings. And Paula Tupper, that is a registered nurse, that she helps us and work us together with all the administrative and management support. How we do this innovation for us is very critical to maintain and build strategic alliances. So for this pilot, we have working together with the municipality of La Florida, that is in Santiago, in the southeast of Santiago, the capital of Chile, and also with the hospital of La Florida and pharmaceutical companies that donate the funding for these innovations. So the interdisciplinary intervention strategy for people with non-cancer chronic pain has the objective to contribute to improve the quality of life of adult patients with chronic pain, improve continuity of care and health system performance by implementing a diverse clinical strategies in the primary healthcare center. Some of the core interventions that we've been piloting are that first, we built a communication channel to improve the coordination, the referrals and contra-referrals with the hospital pain units. And here we have had a strong coordination with the physiatrist and the physiotherapy team that is at the hospital. And at primary care, we basically introduced these four main interventions. First, we expanded the medication basket that, as I mentioned before, we had a strong access barriers and availability barriers of the drugs at the primary health care. We trained the primary care team that is basically not prepared to attend patients, complex patients with chronic pain. Then we added a physiotherapy, pain, neuroscience education, and psychoeducational workshops. These interventions, we add them over the multimorbidity approach that was already installed in the primary healthcare centers that we were working. The population, we designed some inclusion criteria, mainly to prioritize our patients. And because the capacity that we have on the primary healthcare is obviously limited to the human resources. So some of those inclusion criteria are, we are taking patients from 25 to 59 years with 5 main musculoskeletal chronic pain diagnostics: shoulder pain, low back pain syndrome, osteoarthritis of the hip and the knee, fibromyalgia, and rheumatoid arthritis. Those 5 diagnostics, obviously apart, they have the higher prevalence from the diagnostics that are in the musculoskeletal chronic pain. The physiotherapy intervention consists in 4 group sessions that are pain neuroscience education, therapeutic exercise, sleep management, and stress management. And then according to the risk of the MSK tool, that we are applying to all these patients. We offer 10 individual sessions, 6 individual sessions, or definitely no individual sessions for those patients that have low risk. In the individual sessions, we're using these cards that you see here at the left below. That is why we heard that help the clinician to develop the sessions and the education with the patient. Then on the medication, we added mainly three new drugs, the duloxetine, pregabalin, buprenorphine patches. And then we released some of those restrictions that I mentioned to you before about quantity and the period or the diagnostic for the celecoxib, tramadol drops, and paracetamol. So this was like a huge change for patients that before this they had to buy it and cost 100% of those medications. Now they can access to those medications at their proper center. The psychoeducational cognitive behavioral approach consists basically in 6 workshops that the topics are from the welcome, then they work the emotions associated with the experience of pain, the active acceptance, focusing attention and negative thoughts, communications, and then relapse prevention. About training for the health teams, we've been working very hard with them and very frequent, so they can not only learn the academic or the technical or the scientific basis of the chronic pain, but also give them a support during the different cases and the different patients that they're attending in their health centers. So we started with providing them internships at the Unit of Chronic Pain of the Universidad Católica. Then they did some courses about general chronic pain, evaluation, medication and non-medication treatment. Then we provided modeling and technical follow-up in physiotherapy, psychological approach, and also for the physicians. We have performed also twice a month virtual clinical cases review, where we see complex clinical cases, technical aspects, or deepening some academic topic. We have also done medication trainings and technical seminars. About the implementation process, what we have gone so far, from the Centro de Innovación en Salud Áncora UC, what we've been working with the clinical teams in the local context is mainly addressing barriers that are proper of the complex interventions, such as the transition or the navigation of the patient inside the center, how the different professionals communicate, are the patients assisting to the different workshops, etc. If we cannot find solutions with the clinical team, we search for solutions on the best practice around the world. We contact the academics and then propose solutions to the different barriers. We coordinate between the different stakeholders from the hospital, the Ministry of Health, academics, and the Centro de Innovación. We provide also academic support and feedback every time the clinicians ask for help. They have complex patients or different insights that they need to get to provide a better care. And also we constantly monitor the advance of the intervention in terms of how many patients have been receiving this intervention, how is the no-show rate behaving, the drug availability, etc., and try to consolidate the intervention in order that when the piloting period finishes, the intervention can be inserted and run smoothly in the daily operation of the primary healthcare center. And also we provide funding for the clinical human resources, training, and other operation expenses. How are the patients that we've been intervened? Mostly they're women. 90% of our patients are women. The median or the average of age is 49, approximately. Women are 49, men are 44. And the main diagnostics of these patients are low back pain and fibromyalgia. Those are like the biggest number of patients. About the physiotherapy intervention, we have up to date we have performed 50 workshops. That the workshops that I mentioned before, and the no-show rate is at 35%. We know that at least here in Chile, the no-showing rate in physiotherapy is very common. From 10 sessions, patients from the 5th or 6th, they don't come anymore. So this no-show rate is not like a big surprise for us. And about the psychological workshops, we have performed almost the double of physiotherapy workshops, but here the no-show rate is a bigger problem that we are trying to address and to improve the patient's assistance. Further challenges that we're looking to, already we have generated a clinical intervention strategy that is available in a document. We have consolidated this intervention with our colleagues, the clinical team, the academics, and we have also developed a neuroscience pain physiotherapy workshop guide, the psychological education workshop guide also, a medical training and follow-up program. From all these modeling courses and medication training, we have developed medical training to provide new skills and knowledge for the approach of chronic pain patients. Also medication training and restrictions release. And we have also developed patient experience audiovisual materials, such as videos, that we can share with the different stakeholders. And now we are in the phase that we're expanding the pilot to another primary healthcare center in the same municipality of La Florida. And in the short period, we're going to perform the health services utilization impact to see if we are having a positive impact on the utilization, mainly of the medical consultations at primary healthcare. Thanks. I hope you enjoy this innovation and the piloting experience shared with you.
Thank you so much, Paula. That was incredibly interesting to see how, through systematic and rigorous research, we can implement innovations related to chronic pain in Chile. Thank you very much. I'm sure who are watching us might have comments and questions around your presentation and your experience, of course. Thank you. I will now invite our second panelist. She is Jajit Mankelo. She's from University. She's a lecturer in rehabilitation science at the School of Health and Life Sciences, an early career researcher and a physiotherapist. Dear Judge, thank you for being with us today. It's a pleasure and an honor to share this screen with you. And please do go ahead. You have your 20 minutes to share your experience and knowledge around chronic pain at Teesside, England with us. Thank you very much.
Thank you very much. Are you able to share Cormac's slides with me, Baltika? I can go through them. And if not, that's not a problem. I can talk about
I am afraid I don't have them at this very moment. I'm going to check, but in the meantime, you may just start and I'll see if I have them with me. And if I do, of course, I will do. Thank you.
Thank you very much. So my name is Jaj Mankelo. I am an early career researcher and a lecturer in rehabilitation sciences and also physiotherapist. My pain science education research started at Teesside in 2017. I did a 4-part PhD supervised by Dr. Cormac Ryan, and there were 4 studies that comprised this PhD. The first study looked at what healthcare students learnt or knew and believed about pain management in their first year. It was a cross-sectional study, and it looked at final year students across 12 universities in England, Ireland, Northern Ireland, Scotland, and Australia. And we found that amongst the 6 disciplines studied, so we were looking at nursing students, paramedics, midwives, physiotherapy students, occupational therapists, and diagnostic radiographers, we found that there was actually very little change from first to final year pain knowledge, attitudes, and beliefs. The only group that did show a change were the physiotherapy groups, and the change in pain knowledge, attitudes, and beliefs were significant, statistically significant. I have published all of this work, and I'm sorry, I'm stepping in for Professor Ryan just at the minute. But if you're interested in any of that work and you're unable to find it, please do let Baltica know and we will help you access it. The second study looked at longitudinal changes in knowledge and attitudes between physiotherapists and medical students. This was a secondary analysis of data that was gathered at Glasgow Caledonia in early 2010s, and both medical students and physiotherapy students showed quite a change in statistically significant change in knowledge and attitudes towards pain from first to final year. This was a study that followed students during the duration of their 4 or 5 year course. Again, both of those studies have been published. We then did a systematic review looking at the effects of pain science education upon knowledge, attitudes, and beliefs with meta-analysis. And we found that any biopsychosocial study that measured those outcomes showed there was a definite change in pain knowledge and intentions to behave in a guideline consistent manner following biopsychosocial pain education. Interestingly, the study showed that the length of the education did not affect the outcomes. You could have short periods of education up to 70 minutes that would make quite a statistically significant difference. However, all of the studies that we looked at examined single disciplines, and there was no medium-term follow-up. So finally, for the RCT, my final study, the randomized controlled trial, we examined the effect of a 70-minute PowerPoint presentation, largely didactic, and delivered by Professor Cormac Ryan, who's here now. And we found that there was a short-term and medium-term carryover in terms of knowledge, an improvement in knowledge and attitudes, and the intention to behave in a guideline-consistent manner. However, the retained the statistically significant findings lasted only for attitudes and intention to behave in a guideline consistent manner in pain management. And at this point, I'm going to hand over to Professor Ryan, if that's okay, to present his slides. Thank you very much.
Hi, everyone. Please accept my apologies for being late. I was getting
right.
I'm sorry, Baltica. I was getting my Wi-Fi off my phone, and my phone decided it was too hot in the car to work. That only happens once every decade in the UK, and it gets that hot.
Don't worry, it happens. Thank you for joining us. I know how hard it is to juggle with everything, so that's absolutely all right. And Judge did a wonderful job while you were coming, introducing different studies. Let me just introduce you and say hi to you. We have now Professor Cormac Ryan from University. He's a professor of clinical rehabilitation over there, and he's going to share with us, just as Judge did, as a sort of a summary or a synthesis of what you are probably going to share in depth now. So please do go ahead. Cormac, you should be allowed to share your slides, and please do go on with what Judge has already introduced. Thank you for being with us.
Lovely. Thank you, Baltica. Can everyone hear and see me?
Yes, that's absolutely fine. You might want to go to presentation format. There you go. Wonderful.
Yes, I've just popped it into presentation format there. So hopefully we should have no more hiccups from here. Okay, so yes, my name is Cormac Ryan. I'm Professor of Clinical Rehabilitation at University. I'm also the Community Pain Champion for the Flippin' Pain campaign. It's a real honour and privilege to be speaking to you today. I want to start off with a quick declaration of conflicts of interest. So I'm a named inventor of a medical device for the treatment of phantom limb pain. I'm also leased out by University to be the Community Pain Champion for the Flippin' Pain campaign, which is run by Connect Health. With all of these conflicts of interest, I had hoped that right about now I'd be sunning myself in some Mediterranean port, but unfortunately the reality is not quite as rosy. Persistent pain is a huge problem. It affects over a quarter of people worldwide, and here in the UK it accounts for over 26% of the years lived with disability, and it's the largest global contributor to years lived with disability. So it's a huge, huge problem. Certainly here in the UK, but I think in many countries, in order to tackle this problem of persistent pain, we've been taking a primarily biomedical approach, increasing the use of biomedical interventions such as opioids, surgical interventions, and the use of scans. However, this has made very little impact upon the problem. If anything, the problem of persistent pain is getting worse, and the associated disability associated with it is increasing. Why is this? Well, why are we continuing to take a biomedical approach to a condition which is biopsychosocial in nature, and all the best evidence and guidelines say that we should be using biopsychosocial approaches such as active physical and psychological therapies rather than biomedical based interventions? Well, I believe that the literature indicates that it is a large part of the problem is public understanding of persistent pain, which is primarily biomedical in nature. These are some examples from surveys of different countries around the world. If we see the top one from New Zealand, almost 90% of people think it's easy to injure your back. We also see here that a lot of people still think you should avoid exercise if you've got chronic pain, that you should bed rest is a good treatment, and that you need imaging or scans, that it's a sign of serious disease if you've got back pain, and that if the pain doesn't go away, you should take it easy. You should avoid physical activity. These are the common beliefs of the general public, and they're all inconsistent with a biopsychosocial approach. If we look at what the average man on the street or the average person on the street thinks about persistent pain, I asked Google to give me a picture of the average man on the street, and this is the picture that Google gave me. I'm not so sure about whether this is what the average man looks like in Chile, but over here, certainly Google has probably an unrealistic picture of what the average man might look like. But I believe the average person thinks that pain only occurs when you're injured, and that the greater the injury, the greater the pain will be, and that persistent pain means that an injury has not healed. Whilst these all seem like logical, reasonable statements, they're actually all misconceptions or myths, and they form a barrier to good management. These this understanding of pain is very much based on an old, outdated biomedical understanding of simply pain reflecting the state of the tissues. But we now know that pain is far more complicated than that, and understanding that complicated element of it can actually be beneficial. Over the past 70 plus years, the scientific community have learned a great deal about persistent pain, but very little of that has trickled through to the person on the street. And as such, there are many myths and misconceptions about persistent pain, which act as barriers to good management. We believe that knowledge is the key to success. If we can take this scientific information, put it into the hands of the people who need it the most, the person with pain, their friends, their relatives, their healthcare professionals, we believe we can bust many of these myths, leading to better pain management for all. Now, there's an approach to pain education called pain science education, and it's based upon the textbook Explain Pain, which some of you may have come across. And this pain science approach tries to shift one's conceptualization of pain from that of a marker of tissue damage or pathology to that of a perceived need to protect bodily tissue. Tries to shift people away from the old, outdated biomedical view of chronic pain towards a more biopsychosocial view. Now, this approach has been used commonly within a clinical setting. And this is a systematic review published by one of my PhD students, which demonstrates that delivering this type of education within the clinical setting can help people to reduce pain-related fear and anxiety and shift beliefs in a positive way. Now, in Australia, Lorimer Mosley's group is taking this pain science education, which has shown to be effective within a clinical setting, and it has moved it into the public health setting. And in Australia, they have their pain revolution. So that's the name of their campaign, and they cycle in a peloton tour from rural community to rural community, delivering pain science education engagement talks to try and improve public understanding within those communities of pain. In the UK, our equivalent of that is Flippin' Pain, which is based very much on the pain revolution approach. And Lorimer Mosley is also one of the consultants on this campaign. It's run by Connect Health, as I mentioned, and it's been commissioned several times by our National Health Service in various different areas. The Flippin' Pain has 6 key messages. That persistent pain is common and can affect anyone. Hurt does not always mean harm. Everything matters when it comes to pain. Medicines and surgeries are often not the answer. Understanding your pain can be key, and recovery is possible. And it tries to change the way that people think about, talk about, and treat persistent pain, away from the old biomedical view towards a more biopsychosocial view. How are we doing this? We're doing it through a variety of different community engagement activities. The first one is our seminars. So we do town hall seminars in local communities, and there's a picture of one just in the middle, where it consists of a 45-minute talk from what we call the sage on the stage. So a scientist such as myself talking about pain science education to try and give that knowledge to the people. And then there's followed by a 45-minute questions and answers session led by people with lived experience of pain and clinicians talking about the material with the audience. When COVID hit, we moved these online and we had webinar equivalents, and it was really revolutionary. Our reach increased enormously. We went from having 100 people at our events to, in some cases, having over 3,000 people at our events. So it was brilliant. It's never quite as good online as it is in person, but the reach was fantastic. So we have these seminars and webinars that we keep both going. We've also got an online presence where people can see real life stories of people with lived experience who have taken on this information and very much changed the way they've approached their pain, which has led to recovery for them. Of course, recovery meaning different things for different people. Then we also have a variety of different resources on our website. Some are just links to external sources. Others are bespoke resources that we've made ourselves to communicate the key message. We also do our Peloton tour. That's my daughter, top left there, getting into the spirit of our Peloton tour. So much like the Flip and Pain, not the Flip and Pain, the Connect, the Pain Revolution in Australia, Flip and Pain cycles. For 1 week in the year, we cycle from local community to local community, delivering outreach events. This year was 7th to the 12th of May, where we went around the Tees Valley, which is the area that I am based in. Alongside that, we also have our brain bus. So our brain bus is another activity we use to communicate these messages. The brain bus is an experiential learning activity where we engage the public in various different illusions and both physical, visual, auditory, and using virtual reality, the rubber hand illusion, all sorts of illusions to try and help people to understand how our brain influences what we experience. And then we shift the conversation away from that experience towards pain to try and communicate our key message that everything matters when it comes to pain. Pain is a biopsychosocial experience. Okay, so I'm going to give a little flavor of that just now. Baltica, I see you come on. Have I run out of time already?
2 more minutes, is that all right?
2 more minutes.
I'm so
right.
sorry. Thank you.
No, not at all. It's my fault for being so late. I'm going to skip that and I'm going to move on. Okay. So this is our an example of us doing our brain bus thing and cycling around the communities, a mixture of scientists, clinicians, and healthcare professionals and people with lived experience. I'm going to briefly then show you, this is just totally non-scientific, but here's just some unsolicited feedback we got from people. So this is a lady who came across the brain bus and said, so I came across the brain bus. I'm really grateful for the information about Flip and Pain. I'm very fit. It's helped me enormously already. I'm a very fit, active 60-year-old who has had 20 months of pain and SI joint pain with the MRI showing no tissue damage. 1 month on, I'd say the pain is now 10% of what it was. We were really intrigued by this, so we contacted her and said, what have you done in the past month since talking to us? And she talked about the idea that listening to the seminars, it just all made sense to me, especially as I've had lots of physio. I've never come across this knowledge before about your nervous system and how it can overprotect you. It was explained so well. I'm fascinated by it. And she goes on to talk about how it's helped her to get more physically active. And then this is the last one where another unsolicited contact from a person who had attended went on to say that after coming to some of our events where she began to understand her pain better, said she was now 17 years later, it was the first time she had been off opioids after being on them for 17 years. Exactly what we had hoped to happen. Giving this information engages and empowers people to make positive changes to how they are managing their pain, shifting away from outdated, non-evidence-based care towards more active physical and psychological therapies. I don't have time for that, but I am going to finish up by thanking very much Pain Revolution for all the support they give us with our Flip and Pain campaign. I'd like to thank all the people with lived experience, the clinicians, the scientists, etc., who helped to put together the campaign. There's some references. Thank you very, very much for listening.
Thank you, Cormac. Sorry I had to rush you. Thank you for this great presentation. It was great having you, and we can totally see how much having the slides and the stories behind them brings a lot more of understanding of what you've been doing with Judge in terms of community-based interventions, which are parallel to clinical interventions that Paula just presented. So it's really interesting to see how first chronic pain is such a huge public health problem everywhere, how prevalences across countries are fairly similar, but also that innovation that is produced is different according to context, and that's fascinating. Thank you so much, dear Cormac. I will have now comments from Judge and Manuel. Manuel, you're on, so I'll introduce you first. Cormac, thank you. So Manuel, as you know, he's Associate Professor of Health Economics at PUC. He's a medical doctor. He's got a master's in biostatistics, in epidemiology, and in health economics, and a PhD in economics. You have been working, Manuel, around chronic pain for some years here in Chile, so please do go ahead with your commentary based on the two previous presentations. You've got around 6 minutes. Thank you very much. Manuel, can you hear me?
Thank you very much, Valtika. Can you hear me? I got an unstable connection now. Can you hear me well?
Yes, I hear you well.
Okay, thank you very much. Well, first of all, thank you very much for this opportunity to share some thoughts on this. A special hello to my colleagues, Cormac, Paula, Faye, Janhit. It was fantastic to see you again today since our visit to T-Site in February. Let me start highlighting some history of how the problem of chronic pain becomes part of the public policy in Chile in particular. In 2014, almost 10 years ago, the Chilean Society for the Study of Pain, which is a local chapter of the International Association of the Study of Pain, came to us in the university as academics who were working in health economics, public health, and public policy to express their concern about how invisible was pain at that point as a public health problem. At that time, that society was very successful in putting the oncologic pain in the public health agenda, which was taken by the Ministry of Health as a big problem. This led to the implementation of pain units for oncologic pain in a large number of hospitals in Chile. But the non-oncologic problem was not included in this policy. And of course, this is a very prevalent problem, and the health system was unable to tackle it at that point. It would have required huge amount of money and also huge amount of resources, human resources, that were not available at that point. But the system was handling the demand for chronic health, for chronic pain in a very bad manner at that point. We faced multiple consultations, repeated consultations. The treatment was limited to non-steroids, anti-inflammatories, in some cases physiotherapy, but very limited. And in most cases, the problem was not integrated with other diseases that the patients suffer, which is basically most of the cases with people from having chronic pain, they suffer from many other conditions. So at that point, we performed the first burden of disease study of chronic pain for Chile in 2015, which we updated now in 2019. Previous burden of disease studies in the country were very important to define priorities, but none of them included pain, basically because it was considered a symptom and not a disease or a health problem. Hence, by including pain and specific conditions, we identified that the first cause of burden of disease in the country was low back pain. The previous studies we had identified that as the first cause of burden of disease, cardiovascular diseases, but not pain. So for all of you who are not familiar with this metric, burden of disease measures how sick is the population overall in terms of disability-adjusted life years, and often present this DALYs, these disability-adjusted life years, in terms of how different diseases explain most of the overall disease. So the burden of disease is used in many countries, especially in low and middle income countries, to define public health priorities. So in Chile, we used burden of disease 20 years ago to prioritize, for example, as I said, cardiovascular disease and cancer. But those studies, again, as I said, did not include pain, and in particular, low back pain. Hence, our studies became a benchmark for the policy discussion. If we would have had that information before, we probably would have prioritized pain in the priorities of the health system. So in addition to the burden of disease studies, we also developed 2 studies in the last 8 years to characterize how much is the expected cost of pain for the health system in terms of direct and indirect costs. And finally, in 2017, we also developed a proposal for a public policy to address non-oncologic pain in the system. The interesting thing of this story is that all these studies contributed significantly to the public discussion. They were used by congressmen and congresswomen, the MPs in Chile, to ask the Ministry of Health for taking leadership and proposing improvements, and also for the production of what now we know as the first law of pain and fibromyalgia, which was recently launched in last January in Chile. We're very proud to share this experience because it's one of the examples where academic and university work becomes essential for public policy. But now we have another few challenges, which is now how we're going to implement actions that are going to be effective in the population in a context of very limited resources. As many health systems of the world, the Chilean health system is facing the consequences of the pandemic, facing long waiting lists of those patients that were postponed because of COVID, but also the broad economic consequences that limit the availability of resources for the health system. Unfortunately, the law forces the health authorities to take actions right now with the resources they have. So the question is what to do in this context of limited resources and huge population needs. Well, we need to start recognizing that in this area, some of the additional resources we invest in providing better care are justified not only in terms of better health outcomes that we can produce, but also in terms of better performance of the healthcare services. So actually, we expect that patients who are better managed will demand less services later on. And the use of the resources is going to be more efficient than using the model of care we have now in place. This is the context where the initiative that my colleague Paula Zamorano presented, becomes an innovative program. The idea of these pilots is, as Paula said, to improve health outcomes, but also to produce some innovation in terms of how the system uses resources in an efficient manner, basically decreasing the future demand of these patients later on. Let me share another idea that it is worth noting that this initiative was passed to the group of the University of PUC because of some important previous experience that Paula and colleagues implemented, and I also had the opportunity to contribute to that. Our university implemented the first program that changed the model of care in primary care in Chile, passing from a model anchored in health programs, which focuses pretty much on the health problems, for example, the mental health program, the cardiovascular program, etc., to a different model, which we call a centered patient model, where the patient is stratified based on his or her risk, and hence patients with multimorbidity that will be at higher risk than patients with only one condition are going to receive different care. So
you've got 1 extra minute.
Okay, based on this stratification, patients receive a different management where high risk receive an interdisciplinary care and low risk patients receive a more basic care, emphasizing in self-care and other relatively less expensive but effective services. So after 3 years of follow-up, we found very significant improvements in health system performance indicators, mortality, and also the use of the health system resources. So this was the previous pilot of Paula's team and colleagues, which now is a program led by the Ministry of Health, which is now being implemented in the whole country. However, pain was not included in the original multimorbidity model of care, but we can imagine the huge implications of including pain in the model, since it requires a lot of capacities in the system that are not in place yet. So actually, for managing pain, the system is far behind compared to more other classical problems like hypertension or diabetes. Therefore, implementing these pilots for pain in the health system is very important to explore in the future how to integrate it in the general model of care based on multimorbidity. So my final word here is, as you can see, our work in Chile has been much focused on innovations within the walls of the healthcare system, but we have to acknowledge that we have not been very innovative in interventions beyond these walls of the health system. This is why I consider so important these meetings. And when I listen to Cormac's presentation, I see there are a lot of things we can learn about public health interventions in particular, but also the new innovations within the health system. Of course, we need to do something in the health system, but we also need to be efficient to maximize health production of our population. And for that, we need to think about interventions at the community level. I'm going to stop there. Thank you very much.
Thank you, Manuel, for your very articulated and deep comment on the previous presentations. I will quickly move on to Judge again. Dear Judge, welcome again to the screen. You've got your 6 minutes to share your thoughts around what we've been listening to in the past few minutes. Thank you very much.
Thank you very much, Baltika. Hello, it's me again. I shall be brief, but I did want to say, Paula, Manuel described your work as innovative, and I really do think it is. One of the things that really stood out for me was that you've recruited pharmaceutical companies to work with you, which is, I think, a stroke of genius, actually. I would love to hear more about how you've done that and what you've observed in terms of the expanded medication basket that you talked about. Did you notice a decline in medication prescription? I'm not sure, but it sounds like you've had a really broad team involved with you as well, with sleep management, not just stress management on board. It just sounds like a really comprehensive intervention that you've had there. And I think probably anybody who's viewing this video would love to have access to any of the publications you've produced to look up the work you've done so far. I was somewhat comforted to see that Chile's incidence of persistent pain is not dissimilar to ours. It seems such an enormous problem where I practice. So it's interesting to hear what's happening elsewhere. Also, I noticed during your presentation that it looks like you undertook this work during COVID, which I think is highly commendable that you were able to do that. And I'm also very interested to know which knowledge mobilization models you use. I appreciate you had a very short period in which to present, and I'd love to know what kind of barriers you faced. But this is a huge intervention that you undertook, and I'm really looking forward to hearing more about it. Finally, I've got a point for Cormac from the point of pain science education. You had a brief summary from me where I stepped in to tell you about my experience with pain science education. I continue to work with Cormac in pain science education. And we are increasingly approaching school groups to see if we can make a difference to the next generation with our pain science education. We've currently got a randomized controlled trial underway. But I think it's interesting to observe. I was asked about the recent Flip and Pain tour that we did in the Tees Valley, and I was asked if there were any consistent themes coming up. And one really interesting theme I've started to notice, this is my third Flip and Pain journey to talk to members of the public, is that increasingly we're being asked about things beyond MSK. And obviously I can talk generally about pain, but I think it would be really interesting to see where Flip and Pain goes. I've been asked increasingly about obs and gynae pain and how what we're saying translates to that particular field, but also I've met people with other pains that have been attributed to abdominal disorders, and I think it'll be really interesting to see how this public health campaign grows in the future in a non-MSK context, if indeed that will happen. But ultimately, I think there's some great examples of work going on to combat persistent pain, chronic pain, and I'm loving being part of this journey. It's just growing. There's still a lot to do. We can't just stop and pat ourselves on the back and say, yay, job done. There's a lot more to do, but the progress is encouraging. Thank you very much, Baltika. Thank you, all the presenters.
Thank you, Jad, for this very sound and again really interesting comment on the vision of chronic pain across countries. I will now give the lead to Faye Dean. She's an academic at TZ University. Dear Faye, welcome to this session. Thank you for waiting all this time to be here on the screen. And you've got your 10 to 15 minutes top to share some questions with our panelists. So do go ahead. Thank you very much.
Hello, everybody. And this is firstly to anyone who's listening. If anybody does have any questions that they would like to put in the chat, please do put them in now. Currently, there aren't any, so I have some questions for the panelists. But if I see some filter through, I will go through them. So first of all, I thought they were really, really interesting discussions, and actually the overlap between countries globally. You know, it's quite comforting that we're all on the same page, and it seems like there's a definite paradigm shift from biomedical to psychosocial. Paola, I thought the healthcare system approach that you use in Chile is really, really interesting. You know, integrating healthcare services like that to create an efficient way of managing pain is really, really important. And I find that really interesting, like Jad said, that you incorporated stress and sleep. I also, as a healthcare practitioner, obviously there's a huge association between, for example, low back pain, which is one of the largest causes of disability, and depression. And I wondered if there were any at all, Paolo, if you were looking at the association between them as part of your study in that healthcare system, if you factored for that. Paula? No?
Yes.
Yeah.
Sorry, can you repeat me the question?
Yeah, hi. I just wondered, obviously there's a huge association between pain and mental health issues such as depression. And I wondered, how did your team account for that psychological aspect of managing that, or have you evaluated that yet? Or is that something you plan to do?
Yes. Here in Chile, we have a very strong mental health program. But what we did is we added these 6 workshops from a perspective of cognitive, behavioral, psychological workshops. And there we integrated depression and other mental health issues from the chronic pain perspective.
Okay.
I don't know if that answers your question, but we just joined together the mental health program with these other 6 workshops that are offered along the physiotherapy workshops on neuroscience chronic pain.
That does answer my question, thank you. And just while I've got you, I'm really fascinated in the operational process of how each patient is managed. Does each patient have a case manager who's a medical doctor? How does that work operationally?
Yes, here in Chile, we have a strong implementation of the family medicine, family and community model, and the multimorbidity approach. So every patient has a primary care team composed by physician, nurse, psychologist, midwifery, nutrition, and so that primary care team follow up the patient, and on top of that, we added the chronic pain approach.
Okay.
We didn't want to introduce a parallel program or a parallel intervention. So we had made a lot of effort for this program to introduce into the multimorbidity approach instead of being a side.
Okay.
Yes, so the case management, we have case management, but only for those patients that have high risk. for those
Okay.
that are more complex, and the case management is based on the multimorbidity approach, where all our chronic patients are inserted.
Okay. Brilliant, thank you for that. And I know previously that an economic evaluation has been carried out on the multi-morbidity approach. Do you plan to do an economic evaluation on the pain factor specifically?
Yes. One of our first questions was, okay, we're going to add human resources on one side. On the other side, patients are not accessing to medication on their health system. Rather, they're buying them and spending from their own pocket. So our focus was is to evaluate the impact on the physician and non-physician consultations, the impact on the cost of the medications, and the impact on patient satisfaction. Yeah? But the economic evaluation mainly is going to look for the health services utilization at primary health care and drugs and medication therapy, right? We also would like to evaluate the absenteeism and productivity losses. Here in Chile, we have a license or medical leaves. I don't know how you call it in the UK, but if we get that data, we could also evaluate the impact of productivity.
Okay, fabulous. Well, you have to keep us posted.
We'll probably do that evaluation during the second semester.
Okay, I was going to say,
and our team. Yes.
We will keep a lookout for that then, because that sounds really fascinating. Thank you so much, Paula. It's been really, really interesting. Thank you.
Okay, thank you too.
Thank you. And then Cormac, thank you again for a really good, interesting presentation. It was really good to actually just hear you reinforce, the public perception on pain, and actually how people still think that bed rest is important and people shouldn't move, and how, like you say as well, we typically treat from a biomedical approach, which again is really outdated now. So it sounds like the impact of your research obviously started at community based, but actually you've got a lot of scope for a greater impact now that you can go online with Flipping Pain. I just wondered how you can improve guideline management and keep that consistency through the research you're doing, and how you plan to do that in the future.
I think it needs to be more than an educational approach. So what we're doing is I'm really proud of it, and it's great, but it is only one approach. And I think listening to Manuel's presentation about a sort of a coordinated effort, something that's that was around multi-morbidity, but you can take the same principle and bring it to chronic pain, and think of a multi-arm strategy to try and address it. Public health education, yes, absolutely, but it needs to be more than that. And if you look at previously particularly successful public health initiatives, things like motor vehicle safety and tobacco control, both of those have been extremely successful in terms of reducing deaths related to cars and tobacco, etc. And one of the reasons why they were successful is they developed a sort of a groundswell of public acceptance of the appropriate behaviors and approach. It wasn't just informing people about it. It was once people began to get these messages and really believe in them and become sort of a motive about them and motivated by them, then the public themselves, there's a change in their attitude and view. And once there's a groundswell of public change towards a topic, that's when politicians start to take on board what's being said. That's when you begin to see changes in policy. That's when you begin to see changes in the whole communities. So I think to move this forward, we need more and sustained public education stuff for sure, but we then need to try and harness the groundswell in change in public beliefs to begin to change policy, etc., in ways that are more positive and promote a more healthy approach towards persistent pain.
Thank you. And that's why this is really important, you know, hearing about the research and the amazing kind of public policy work that Manuel's been doing in Chile, and how he has actually been able to affect that change over a period of 10 years is brilliant.
It
and
is.
Obviously,
it's a beautiful example of impactful research, something I'm very, very envious of, and hoping that we can replicate something like that this side, because it's the alignment between research, a focus of the question, the quality of the research, and then actually disseminating that in such a way as something gets done that's worthwhile. That's really beautiful to see. If we can replicate something even on a very small scale in that way, it will be wonderful.
Absolutely, which is why this is so important, just globally sharing knowledge, like we say. And I love your idea, because when I was listening to your talk, I was thinking about how we need to implement this at a grassroots level. First of all, educating the educators, but then also I love the way, because in my head as a primary healthcare practitioner, I was thinking, how do you explain something complex like neurophysiology to patients? And then you brought on the brain bus, and I thought, what a clever idea, how to translate that across. And Manuel's popped up there. I also wonder how, you know, if they have a similar way of doing things in Chile in terms of education. I'd be really interested to hear how you both do that.
Wow, maybe I'm not the right person to answer that question. I'm in the world of evaluating of some really interesting, innovative ideas that someone came up, and I'm in the world of the evaluation. I'm not sure if maybe Paula or Baltica knows something about the education. To be honest, I don't want to. I'm not aware of that any evaluation on that field, really, education. Sorry about it.
That's okay.
I'm going to be very cautious about.
That might be cool, Mike. You might be the best person there. And
in terms of evaluation of public health interventions for persistent pain, there is some stuff out there, but it's nuanced. So in the late 90s, early 2000s, there were a number of initiatives, primarily around back pain. They were called things like working backs, don't lie down to back pain. Those were the sorts of titles of them. And they had the same key messages, primarily of, you know, if you've got back pain, don't go to bed, try and stay active. You know, good messages. They were, I would say that they were more telling people what to do rather than why they should do them. So whilst they were brilliant, and I liked them a lot, and they did demonstrate effectiveness, I'm more drawn towards this new approach that we're doing, because I think if people understand why they're being asked to do things, it might generate more sustained change and engagement. That's only a hypothesis. It doesn't mean that it will actually happen, but I believe that it's an important part of it. There's been a number of big studies. The big study in Australia in 2003, published by Rochelle Buchbinder, with the old don't lie down to back pain approach, was really, really compelling. They had some health economics components to it, showing that there was a reduction in back-related injury claims, and that reduction in claims far outweighed the costs of delivering the campaign, which was really multimedia. It had celebrity endorsement, it was TV, it was radio, it was really, really big. No other campaign has replicated that huge size and volume, and thus no other campaign has replicated that level of impact. There was a public similar study done in France very, very recently that's just published its results. Again, it was mass media, radio, TV, etc., and they had similar impact, again, from a cost effectiveness perspective as well. So I think when it comes to these sorts of initiatives, big seems to be better. And my goal is that we take a pain science education informed approach like Pain Revolution or Flippin' Pain and do it in a truly mass media way, rather than what we're doing at the moment, which is more taking it from locality to locality. It will be extremely interesting to see what impact that would have from a health and social economics perspective.
Maybe Manuel is the person to lead us with
perhaps.
No, the thing that I wanted to share is it's really interesting, this discussion about whether educational interventions are the best ones, because the other one is what economists would say that are better ones, which are incentives, basically, right? So there is a recently article in the Times, I think in the UK, 2 or 3 days ago, talking about increasing taxes in, rubbish food or something like that.
Yeah.
So the same in, increasing taxes in alcohol and all this, the causes of the causes, right? So obesity, for example, is probably the most important cause for pain, for obesity, for cardiovascular disease, but also for cancer. So how we can do it in a very effective way. So let's increase the taxes of alcohol, of food, of bad food and everything. And then the consequences of that is the behavioral change in people. So is educational the best approach? Are these incentives financial incentives? It's something that is really interesting to me. Maybe there are some principles about what interventions you like, but there are some consequentialist view about what is more effective, really. And I don't have the answer to that. I only have some answers about the evidence of that these increases in taxes are really effective in some particular cases. But yeah, that is another discussion for another seminar, probably.
I was going to say that's a really interesting point to end on, isn't it? A very good thinking point.
It's a really good point, and I totally agree. My hope is that the educational stuff we do creates a fertile bed for those sorts of governmental law changes to occur with sort of public backing. I think, that's when we'll begin to see real change.
Wonderful. I will take now over to you, Faye. Thank you so much for dealing with questions and comments and reflections upon what all of our panelists have said. You've left the screen, but please do come back to say goodbye. We're just running out of time. I want to give a big thank you and a clap to all panelists. Thank you for your wonderful experience, knowledge that you've shared today with all of us. This is streaming live via UDD TV and YouTube. So there is people watching us live, but also people can come back to this video and see it again as much as they can and want. Thank you all. Thank you, Judge. Thank you, Paula. Thank you, Cormac. Thank you, Manuel. Thank you, Faye, for this wonderful webinar. And I hope to see you in a month-ish time for our second webinar. Thank you very much and goodbye.